Hi guys, welcome back. The next topic we're studying is subarachnoid hemorrhage, and this condition has an astounding 35% mortality rate in spite of all the advancements in medical science. And before I get into the causes of it and the manifestations, I would just like to zoom into this image of a non-contrast CT head where you can check out this very famous MCQ that has always been asked in your exam, and you can check out what is classically called as star of death. Yes, the star of death. Well, this is because of the accumulation of blood in the basal cisterns. The blood that accumulates in the subarachnoid space due to gravity would then move down toward the basal cisterns, and that is responsible for this very classical non-contrast CT head image that is star of death. And with these words, we can now focus on why would we be having a subarachnoid hemorrhage, and then we'll talk about the manifestations. Just be careful about the fact that don't straight away mark it as rupture of berry aneurysm, because the textbook says that the most common cause is rupture of berry aneurysm excluding trauma. So that word excluding trauma implies that trauma happens to be the number one cause responsible. And after trauma, the next cause to be remembered is obviously what I said, that is a rupture of berry aneurysm. And well, various berry aneurysm present, then we'll talk about the various permutation combinations and the manifestations with respect to the location. But one of the commonest location that you're aware of even from your basic sciences classes would be anterior communicating artery, where it meets with the anterior cerebral artery. Now in berry aneurysm, there is a defect in the internal elastic lamina of the blood vessel that makes the blood vessel wall vulnerable to shearing stress, and that it can pop off and that can cause mayhem. And apart from rupture of berry aneurysm, another important cause to be remembered is arteriovenous malformation. Then can be dural arteriovenous fistulas as well. And while doing these MCQs, I mean, obviously these standard causes have to be remembered apart from point number 1 and 2. But in some questions, you will come across a complication of subacute bacterial endocarditis. Yes, one of the complications that we are aware of where you could be having a possibility of subarachnoid hemorrhage is mycotic aneurysm rupture as well. And this mycotic aneurysm is a complication of subacute bacterial endocarditis. In fact, if you read this name, no, it looks like mycotic word basically gives a semblance that we are talking about a fungus, but then obviously you are aware of the fact that this would be due to Staphylococcus aureus that would be seeding the blood vessel wall and would result in a mycotic aneurysm that can pop off at any point of time, again resulting in subarachnoid hemorrhage. The next cause that I'm saying here before you could be a complication of hypertension. Lots of time hypertensive crisis can contribute to development of intracerebral hemorrhage or intraparenchymal bleeding. So it is no big deal that if a person is having intracerebral slash intraparenchymal hemorrhage, then the extension of this can also occur, and this extension can contribute to subarachnoid hemorrhage and even an intraventricular hemorrhage. So specifically in the setting of hypertension, do remember the fact that hypertension most of the time will cause intracerebral hemorrhage with respect to, I would say, a possibility of hypertensive crisis, which has not been managed adequately. And in case we are not finding any cause, then lots of time you will read the textbook saying idiopathic subarachnoid hemorrhage as well. Well, for the idiopathic variety says that the most of the time the source of bleeding in this case could be either venous or it could be capillaries as well. Looks very surprising because when we read about the word subarachnoid hemorrhage, it always tells us that okay, it's gonna be an artery that is responsible. But then sometimes we might be getting a bleed that might be with respect to the brainstem. This would mainly be localized with respect to the midbrain and the pons, and therefore you will read this term perimesencephalic cisterns. And most of the time, with respect to this bleed in the perimesencephalic cisterns, we usually find that the source is not arterial, but it would either be a capillary source or maybe a venous source as well. Overall, when it comes to rupture per se, then the highest possibility of rupture is with respect to the berry located in the posterior communicating artery. I'll talk more about this in the subsequent slide, but I just want to bring to your notice at this moment two very simple statements. One, the most common location of berry is ACOM, anterior communicating artery, where it meets with anterior cerebral artery, but the chances of rupture are based on two parameters. One is obviously the size, and second is going to be the location. So you will notice a large number of MCQs on this topic talking about third nerve palsy. Why that is so is because when it comes to posterior communicating artery berry aneurysm, it's just adjacent to the third nerve, and therefore when this aneurysm will pop off, there would be a third nerve palsy manifesting in the patient as well. In fact, the highlight is the commonest cranial nerve involved in patients with berry aneurysm. Whether he says ruptured berry aneurysm, whether he says unruptured berry aneurysm, is the third cranial nerve. I'll repeat the facts once again. Two statements to be remembered. One, I mentioned right in the beginning, the leading cause for development of this condition is trauma, then is rupture of berry. And the second aspect is, though the most common location is ACOM, anterior communicating artery, a lot of MCQs will be having features that I'll describe before you for subarachnoid hemorrhage, but then he'll also mention third nerve palsy. The moment you read that word, I'll write it down subsequently as well, but the moment you read about third nerve palsy in a patient with presentation of subarachnoid hemorrhage, you are not going to answer that as anterior communicating. You're not going to answer ACOM. You're going to answer PCOM, that is posterior communicating artery, because that's going to be running just adjacent the posterior cerebral artery. Next, focusing on some more baseline data, as I said right in the beginning, the mortality rate in this condition can be huge, 35%. In spite of all that so-called advances in medical science, we have a high probability of losing our patient, and then there will always be a risk of rebleeding as well. Patients of subarachnoid hemorrhage will be advised strict bed rest with even urinating and defecating possibly on the bed only. We will tell them not to laugh, we'll not tell them not to cry, because any emotional outburst can result in development of increased risk of rebleeding. Though I'll be talking about endovascular therapy that will cut down on this risk of rebleeding dramatically, but the chances of rebleeding from a ruptured berry aneurysm is a huge 30%. As far as the chances of rupture is concerned, that's obviously dependent on size. If he mentions a berry aneurysm which is less than 10 millimeter, then the chances of rupture are to the range of about 0.1%. But look at now the sudden change in the data. If he says that the size of the berry is more than 10 millimeter, then the chances of rupture most of the time are between 0.5 to 1%. Well, that may not look very substantial to you, but if you compare the two datas that I've written here, then I think you are noticing that there is a 10 times increase from 0.1 to 1%, right? It's a 10x jump. It is a 10 time increase in the chances of development of rupture the moment the size of the berry crosses more than 10 millimeter. Then he can quiz you regarding giant berry aneurysm. Well, by definition, that would be a size more than 2.5 centimeter. And I would also like to draw parallels with another term, giant duodenal ulcer. In the GI section, you would have noticed me talking about Zollinger-Ellison syndrome. That's a gastrinoma in the gastrinoma triangle. The tumor is in the first part of the duodenum, and that again contributes to a giant duodenal ulcer, which is more than 2 centimeter. So do remember, giant duodenal ulcer, whenever written in a question, is a key word that points towards presentation of Zollinger-Ellison syndrome, and a giant berry aneurysm anyway is more than 2.5 centimeter. And if he says giant berry aneurysm and says what is the location, then do not answer ACOM. Obviously, because anterior communicating artery is a smaller artery, so you will have to answer a bigger one here, and the bigger one would be terminal internal carotid artery. So please pay attention to the fact that if he just says what is the most common location, it is anterior communicating, but if he says the word giant berry aneurysm, then more than 2.5 centimeter terminal ICA. MCA bifurcation is the second best answer in case both are given in the MCQ. And the giant duodenal ulcer part, well, can bleed like hell with respect to gastroduodenal artery, and that can cause torrential hemorrhage, can cause hematemesis and even hematochezia in a patient. The amount of blood loss can be so substantial that even fresh blood in the stool can be present. Next is the aspect of mycotic aneurysm. As I explained to you, this is going to be seeding of the blood vessels of the brain by Staph aureus. Well, the heart in this condition has become the pumping organ, which is pumping bacteria into systemic circulation. Imagine, millions and trillions of bacteria seeding the heart valves. There are vegetations on the heart valves, and every time the valve will open and close, the shearing stress will cause these vegetations to fragment from there, go on into the brain circulation. And as far as the bacteria that is concerned here, the leading cause would be Staphylococcus aureus, or it could even be Streptococcus viridans. Overall, the number one cause for development of subacute bacterial endocarditis is going to be Streptococcus viridans. But apart from this, even Staph aureus can play a role. And then he can ask you, like, what is the site where mycotic aneurysm would be present? So your answer would be that it could be present in middle cerebral artery, it could be in the anterior cerebral artery, because those are the main circulations of the brain, right? But do not answer like straight away the middle cerebral artery. Your technical answer will be first bifurcation of the main artery. Like suppose it could be located in the first bifurcation of the anterior cerebral on the left side or right side, or both possibly as well. Or it could be the first bifurcation of the middle cerebral or the posterior cerebral arteries as well. Overall, the most common location, as I've explained before you, is going to be the anterior communicating artery, where it meets with the anterior cerebral artery. But if he changes that MCQ to where is the greatest, location at the greatest risk of rupture, that's the key word, at the greatest risk of rupture, then one determinant of this would be more than 7 millimeter of size. And the second thing is obviously that this would be located at PCOM. So lots of time he will be writing top of the basilar artery. That's just because PCOM would be a little easier for you to pick up. But when you read the data in Harrison, he says the statement that both of these determinants would be required for a substantial, third nerve palsy manifestation. Berry aneurysm of size more than 7 millimeter. Bigger is the size, higher is the chances of rupture. And then top of the basilar artery at the origin of the posterior communicating artery. As I've explained to you once again, refreshed your anatomy, that PCOM is adjacent to the oculomotor nerve. The usual impression that you get, no, that it looks as if the oculomotor nerve is, anteriorly placed. So it looks like it's close to anterior communicating artery, but that is not the case. It would be located close to the posterior communicating artery. So these are like some baseline data which I would like you to remember for this topic. And then I have just drawn a hypothetical diagram of the berry, and at the neck of the berry, because see, there will be a dome. The rupture will occur here. There would be a dome. Lots of time we can be having sentinel bleeds as well, which means a limited amount of blood might leak before the actual structure gives away. And therefore these patients might have had excruciating headache episodes even a few days prior to the actual catastrophic event when the berry aneurysm will rupture. In fact, the pain rating in this patient would be 10 on 10. That's going to be the most severe pain manifestation that would be experienced by anybody. That's a terrible headache. So that's why the classical term thunderclap headache, worst headache of my life. And sadly, in our MCQs, he stopped using those classical terms. If he says thunderclap headache, worst headache of my life, it's a piece of cake for you. You guys know that even from your baseline classes as well, the classical words thunderclap headache and worst headache of my life. So I'll tell you a couple of data beyond that also. Like suppose in a question, if he doesn't mention regarding the thunderclap headache word, then what are the key words which are to be understood? But in this era of integrated MCQs, he's going to mix up the data. And obviously, like two options can be from general medicine. One could be from the pharmacological intervention of this patient, but then he can ask you from the pathological perspective. And I've sensitized you to this already, that he will say which layer of the blood vessel is going to be involved in this particular case. Now, aware from anatomy and pathology that the layers of blood vessels would be like tunica intima, media, adventitia. And then we also have internal elastic lamina and the external elastic lamina. So in this condition, what basically happens is that when we focus on the neck, the internal elastic lamina in this condition tends to disappear and is replaced by connective tissue. Now, because of the fact that the internal elastic lamina disappears, the tensile strength, the ability of the blood vessel to respond to the shearing stress would be relatively lesser, because fibrotic material is not so powerful. Our strength, the strength that is present in fibrotic material is less than that of the internal elastic lamina, and therefore this blood vessel will now become more vulnerable to rupture. Obviously, I can say the impression is that tunica media is the one that is undergoing a degeneration. That's okay, but it will be secondary to the degeneration of the internal elastic lamina. So if in an MCQ he says tunica intima, media adventitia, then don't mark straight away tunica media. Your technical answer is internal elastic lamina is the first one to disappear. That decreases the ability of the blood vessel to respond to tensile shearing stress, and therefore this berry is vulnerable to rupture at any point of time. And bigger is the berry, more are the chances, and on a comparison basis, the PCOM location, top of the basilar artery location, has higher chances of development or rupture. Coming to the clinical manifestations of this disease, it could be a case-based scenario given to you where he'll describe a 25-year-old female. Let me say she's a software professional. She wakes up at 7 a.m. in the morning, gets up, gets ready for her office, goes to work by 8 or 8:30. But she says that, doctor, I woke up at 5 a.m. in the morning with an excruciating headache. And this headache was so bad that she says I had to, literally get up from the bed and search for a painkiller. And whatever over-the-counter painkiller was available in the house, crocin pain relief, ibuprofen, whatever was available was consumed by the patient. So a 25-year-old lady woke up at 5 a.m. with excruciating headache, and she says I took a painkiller and I waited that the painkiller will start having its effect and the severity of the headache will reduce. But to her dismay, she says that the severity of the headache had worsened by 7 a.m. in the morning that I was compelled to take a second tablet of a painkiller. She says, doctor, the pain was so bad that I took it empty stomach. I mean, normally you see people in India are going to be very particular and usually are going to avoid taking painkillers on an empty stomach. But this lady says that because the severity of the headache tend to increase in spite of her taking a painkiller tablet, so I've written into two to imply that she's taken two tablets of over-the-counter available painkillers, but the severity of headache has worsened in this case. Now she has told her family members that I'm not feeling well and I'm going to sleep. And maybe her mother, late afternoon, because her mother thought that maybe she's sleeping and she's having this headache, so she let her sleep. But at lunchtime, his mother is trying to wake her up, and this girl, she's not waking up, and that's when her mother is panicking because there's a possibility that these patients might have so much of headache followed by raised ICP that sometimes these patients can die. Remember, I told you 35% mortality, and currently this patient has lost consciousness, or she might go into a stuporous condition. Stuporous means patient's eyes will be open, but person will be having mutism. If family member will call out her name and say that, beta, are you okay? And do you want anything? Her mother is telling you that she was just lying with her eyes open, just staring at my face as if she does not recognize me. Or like she's gone into a state of unconsciousness. So loss of consciousness can be a presentation in this condition due to development of raised ICP. And in fact, one of the standard MCQs that is always asked is that what is the most reliable feature for evaluation of raised ICP? Then it's going to be loss of consciousness. Don't answer sixth nerve palsy. Do not answer projectile vomiting. Do not answer headache. Yes, they are present, but the most reliable clinical feature which is suggesting a raised ICP would be a decrease in the sensorium, where the patient will progress from a stuporous condition to a comatose patient. And unfortunately, like, she has become very sick. You see that classical term thunderclap headache. I did not begin that MCQ because lots of time this word will either not be used by Indian patients, or let me say thunderclap headache as a description might be told by the patient only when she will recover. Now she is not in a position to talk. If she goes into stupor, she can't talk. If she goes into unconsciousness state, she can't talk. But when you will treat her by endovascular coiling, when you will use nimodipine in this lady, and when you will make her recover, when she will recover, then she will say that, oh doctor, I suffered from the worst headache of my life. Like, that was the most horrible day of my life, and I suffered from the worst headache of my life. So lots of time, this particular phrase, which is traditionally given in books, may not be actually be the presentation of the disease. I mean, it is a presentation of a disease, but patient is not in a condition to explain it to you. So only when the patient will recover that you'll be able to get these manifestations out in the words of the patient. Now, on physical examination, there will be a very classical finding that would be described, which is nuchal rigidity. And this nuchal rigidity thing is coming up because, just like you know that pus will irritate the meninges in meningitis, there would be blood in the meninges that will cause meningeal irritation. As a result of it, there would be nuchal rigidity elicited in this lady. Now, on reading the word nuchal rigidity, what I've seen is a lot of people make a very silly mistake, which is straight away start thinking in terms of meningitis. Not that your thought process is wrong, but you are aware of the triad of meningitis, no? And one of the features of the triads of meningitis should be presence of fever, right? I mean, without fever, I cannot think in terms of meningitis, and meningitis will not develop over a matter of few hours. Most of the time, the history would be given over 2 to 3 days. So if you're getting a question in which fever is also present, headache is also described, and then meningeal irritation like nuchal rigidity is described, then it is okay. I mean, you should be answering that as meningitis, absolutely correct. But if he talks about nuchal rigidity and a headache kind of a presentation that I have described, where there is a short history, like here, a matter of few hours, a patient, a young chirpy girl, IT professional who's always smiling, always like, a happy, peppy young person. She has gone from a state where her mother is in tears and she's saying, sir, like, I found my daughter at lunchtime. She's complaining of headache in the morning, and like she was in a stuporous condition as if she's seen a ghost and she does not recognize me. I mean, that's going to be the description from a non-medical's perspective. Like, stuporous means the person is awake, but at the same time, I mean, the person is not going to recognize the family members. So that fast deterioration, ultra fast deterioration is going to happen in these patients. And sometimes, meanwhile, like, we might be able to even notice, because this word is again, straight away telling you there is raised ICP. So projectile vomiting lots of time may not be described in a question. The next thing that I'm writing will look very peculiar to you at the moment, but I want you to listen to me very carefully that patients of subarachnoid hemorrhage can be having development of seizures as well. Now let us look at why can be having seizures in subarachnoid hemorrhage. Well, the reason for this is that in this excruciatingly painful condition, there is the release of BNP. The last time we studied BNP, congestive heart failure, right? I've said a blood test that can help in early diagnosis congestive heart failure is pro-BNP levels. But at this moment, I'm talking about B-type natriuretic peptide again. In fact, this B-type natriuretic peptide in this condition will be responsible for development of natriuresis. The meaning of the word natriuresis is salt loss from the body. If you have salt loss from the body, the sodium in the body will begin to fall. Normal sodium values are 135 to 145, take an average of 140. But in this lady, unfortunately, because of the release of BNP, because this is a horribly painful condition, there is going to be extensive natriuresis, which will cause substantial amount of salt loss from the body. This will cause hyponatremia, and therefore the type of hyponatremia that is seen in this condition is itself an MCQ statement. Well, because there's going to be loss of water as well, so there's a volume depletion, and there's a loss of salt as well, so we will simply use English here. If water is lesser, we will call it hypovolemic. If salt is lesser, we will call it hypovolemic. Hyponatremia is seen in patients who are suffering from subarachnoid hemorrhage, and the technical term for this can be cerebral salt wasting syndrome. Just put the English there, right? And this cerebral salt wasting syndrome is the reason for development of seizures in this patient. I'm writing a short form at this moment, but yep, on the next slide, I'll write the full form also. CSWS is cerebral salt wasting syndrome. It's a complication of this condition, and that is why there's development of seizures. Just to see whether you're listening to me seriously or not, just give me an answer. I know it's a virtual class, but still, what is the reason for development of seizures in subarachnoid hemorrhage? Is it because of irritation of the brain by blood, or is it due to electrolyte imbalance? And yep, I know you're nodding your head and saying, sir, you just told us, right? It's an electrolyte imbalance. But usually I find people making mistakes in the actual exam, which is why I made you do this practice. The reason for development of seizures in patients with subarachnoid hemorrhage is not the irritation of the brain parenchyma by the blood, but it would be dyselectrolytemia. So a lot of times in MCQs, no, he might be using this terminology, electrolyte imbalance, that is hyponatremia. The technical term is cerebral salt wasting syndrome, can be explaining this manifestation. Later part, when this lady will recover, she might even tell you that this was the worst headache of my life. And she also says that prior to this also, I had, maybe 2 days before, 3 days before, I had a headache which was not as bad as this one. But if I say this headache is going to be a 10 on 10 rating, she says even a few days earlier, I had a pain which would be, let me say, a rating of 8 on 10 or 9 on 10 per se. So per se, I can say that there can be a presentation of sentinel bleeds in these patients as well. Like sentinel bleeds just mean warning bleeds in this patient. It could be a bleed, it could be bleed. So just put those arrows here to say it might be a single episode or more than one. And she says that I neglected that. That's when the micro leaks were occurring from that berry before that connective tissue gave up, and there was like spurting of blood, and that's when all hell broke loose and this lady suffered from the worst headache of her life. In most of the questions, you're gonna get nuchal rigidity, meningeal signs with headache described, but in some multiple choice questions, you will notice some minor I would say fluctuations in the question as well based on the location per se. Like one of the common famous question that I'll put on the next slide, but I'm saying verbally at this moment is he can incorporate presentation of third nerve palsy. So there could be a unilateral ptosis developing in a patient because the light reflexes in the person will also be affected. So when the doctor will shine a torch, he might be getting a pupil that would be exhibiting a sluggish or no reaction to light. So do take care of the fact that with this kind of a description, the moment he says that there's going to be features of third nerve palsy, you know the location is going to be PCOM, that's posterior communicating artery. Like for example, if the location is in the anterior communicating artery, then the blood supply of the frontal lobe has been hampered. The damage to the frontal lobe results in manifestation of abulia, that means lack of drive. And apart from this, because even the Broca's area blood supply can be hampered, so there could be manifestations of aphasia. For PCOM, that is posterior communicating artery, I've been speaking about this multiple times, sensitizing to the fact that the most common cranial nerve involved in both ruptured as well as unruptured aneurysm is the third nerve. Lots of time anatomy people might say sixth nerve palsy. Yeah, I mean sixth nerve palsy is a feature of raised ICP, so I don't dispute that. But the one that is related to the mass effect, because posterior communicating arteries just adjacent to the oculomotor nerve would be manifestations of third nerve palsy. Because of this, the ipsilateral light reflex in the person will initially become sluggish and then will also be lost. Plus, the eye of this patient would be looking down and out. That's primarily because the medial rectus muscle is not going to function. The lateral rectus will work unopposed, and therefore there would be eye deviation also described. Now, let us say hypothetically that if aneurysm is located in the internal carotid artery, from your anatomy you are aware that the internal carotid artery would be a free floating structure in the cavernous sinus. In those circumstances, because it could be pressing on the adjacent sixth nerve. So yes, sixth nerve palsy can be due to I mean, it's a false localizing sign of raised ICP, but here it's a genuine sixth nerve palsy in case the berry is located with respect to the internal carotid artery. In contrast, if the berry is located posteriorly, that is pica. Pica is a branch of the vertebral artery, and ica, that is anterior inferior cerebellar artery, is a branch of the basilar artery. Then in those circumstances, the headache of the person will be described as an occipital headache, primarily because the anatomical location of these blood vessels is posterior circulation. I said pica is a branch of vertebral artery, ica is a branch of basilar artery, both are posterior circulations. Similarly, if the berry is in the middle cerebral artery, it would be relatively bigger in size as well. That's when it would even be described as a temporal headache. It will mostly be a low temporal headache that would be described. I mean, traditionally we read about the temporal headache in an old person in whom there's a jaw claudication and thrombosed arteries palpable. So you know that you're reading about giant cell arteritis, which is a extra cranial cause or development of headache. But here I'm describing a low temporal headache with respect to berry aneurysm that is on the verge of rupturing, and therefore these extra manifestations based on locations could also be given in the question. I put a star mark with respect to PCOM because that is the one that is more frequently asked. Do not make a mistake by straight away thinking in terms of meningitis. The moment he says about meningeal signs, that's because there would be no fever present in patient with subarachnoid hemorrhage. When I say that, a query from a lot of people is, sir, this lady had taken two painkiller tablets, so maybe that painkiller tablet curtailed the fever. So why are you saying clinically speaking that this is subarachnoid hemorrhage? Well, what I'm trying to say here is that on clinical grounds, agreed that painkillers can contribute to suppression of any fever with respect to meningitis, but the short history that I have described, along with possible presence of seizures in this patient, and more importantly, if he adds the third nerve palsy, because in meningitis, usually we do not have a third. We can get a sixth nerve palsy due to raised ICP as a false localizing sign, cool, but we don't get a third nerve palsy. Obviously, I mean, because of this diagnostic dilemma, we are using a CT scan, no? So ultimately, a CT scan would let us know whether we are dealing with meningitis, where there would be evidence of raised ICP only, but there would be no evidence of any bleed in the sylvian fissure or in the interhemispheric fissure. So I agree to that statement that a lot of people, you know, they message me saying, sir, she took a painkiller that could have curtailed the fever. I agree to that. But considering a short history, even in the MCQ, no, if this kind of an history is given, first differential diagnosis is still not meningitis, and I would still stick to the initial statement that I made. That's going to be answered as subarachnoid hemorrhage. And now let's look at what is the workup of these patients. Now, coming to the workup of this condition, the initial investigation to be done in this patient is a non-contrast CT head. And well, what's going to be the finding seen? We'll be able to see presence of blood in the sylvian fissure. That's the classical description that would be given in large number of MCQs. In some MCQs, however, he may not describe blood in the sylvian fissure, but in contrast, the blood could be described in the interhemispheric fissure. So let me just draw a crude diagram before you so that I can tell you the location of the sylvian fissure and the interhemispheric fissure. So let's take this to be a non-contrast CT head. How do you know it's a CT head? The bone is going to be extremely wide. You'll be able to visualize the lateral ventricles. Let's say this is the third ventricle. And now the structure that I'm showing at the moment would be the sylvian fissure. And this particular area that I'm showing is the interhemispheric fissure. And you could be having blood either in the interhemispheric fissure, or you could be having blood in the blood present in the sylvian fissure. From a lateral aspect, if we look at the brain, right, if this is the parietal lobe and this is the temporal lobe, then where is the sylvian fissure located? This area. The marking that I'm doing is the sylvian fissure. It will separate the parietal from the temporal lobe, and we can be having a bleeding in it, which has been shown on the right hand side. CT scan is the best way for diagnosis of this condition, and then he will ask you what is the next best investigation. The next best investigation would be to go ahead with a conventional cerebral angiography. Why I want to go for a conventional cerebral angiography in this patient is, one, because I want to fix the problem. And what I mean by fixing the problem is that we will be in the same setting when we are doing a conventional cerebral angiography, we are going to be able to demonstrate that there is a berry at a particular location that has popped off, and now we can fix it by doing a endovascular coiling, which basically means that we'll be deploying a platinum based coil in that berry, and that is gonna give structural support to that berry per se. Because see, there is, once the berry has burst, the body will start trying to control that bleed by formation of a thrombus, but that thrombus can get dislodged very easily. This person will cough very vigorously. Like, let me say it's a smoker, he's a COPD patient with chronic bronchitis. If he will cough vigorously, then the thrombus can be dislodged and the rebleeding will occur. Lots of time these patients might be having rebleeding again in the next 24 hours or after 48 hours. We really can't predict. Or suppose this guy is having chronic constipation and he's straining next day, or the next day he's trying to strain while passing stool, and while straining there's a possibility that the thrombus can dislodge, and once again the bleeding can start, and once again the neurological deterioration of the patient, which had stabilized, or there was a plateau of the neurological deterioration, that neurological deterioration will suddenly spike. So because I know the fact that there could be a rebleeding developing in a patient, I am going to deploy a platinum based coil, and I'm going to prevent the development of rebleeding in this patient. The message is, guys, the treatment of choice for this condition should be answered as endovascular coiling. Yes, we're going to use drugs in this condition also. So I'll talk about the role of nimodipine in a while. Nimodipine, agreed, is the drug of choice of this condition, but that's not the first intervention to be done. The first intervention to be done in this patient, obviously, I mean, from a comatose perspective, unconscious patient, I'll secure airway. Like if he says any MCQ, raise ICP. Comatose status, GCS less than 8, and he says what is the first step? Answer is obviously, secure the airway by going ahead with an intubation. But from the perspective, like I want to treat the patient also. No, I mean, securing the airway is okay. I mean, I need to do that airway securement, but the treating the condition is mainly with respect to endovascular coiling, and to do that procedure I need to know the location. So that's why conventional cerebral angiography can be done. If in the MCQs conventional cerebral angiography is not present, then we can also answer CT angiography. I mean, this is one MCQ where he will say, what is the next best investigation to be done after a CT scan that shows blood in the sylvian fissure? The query in the minds of a lot of doctors is that, sir, if blood in the sylvian fissure is already documented, then why the hell do you want to do an angiography? Well, it's not for diagnosis. Diagnosis is already made. I'm not doing it for diagnostic purposes. I'm doing it for therapeutic purposes, because I can fix and minimize the chances of rebleeding by giving structural support to the berry that has burst, which is why I said the treatment of choice for this condition is endovascular coiling. There is one more reason that I would like to tell you why am I doing a cerebral angiography in this patient, and that is because in 20% of cases there can be a mirror berry aneurysm as well. What I mean by a mirror berry aneurysm is that suppose there is a berry aneurysm in the left posterior communicating artery, then in 20% of cases, which is the one in the left has already burst today, then in 20% of these cases, there is a possibility that there might be another berry in the right posterior communicating artery also, though it only 20%, but that's a substantial chunk. And that is a berry which is like a time bomb waiting to explode. So I cannot tell my patient now, okay, there is one berry of yours that has burst, the second one can burst sometime later. When it will burst, then we will fix it. I'm not going to wait for that time bomb to go off, right? In this setting itself, we'll be deploying endovascular coils, two of them, one in the left PCOM, the ruptured one, and the second one in the unruptured one. And therefore, I can prevent the development of rebleeding from the one that is ruptured. And I can prevent the other from rupturing in the very first place. I'll say that again. Suppose on a conventional angiography, if in those 20% of cases, if we are able to document a berry in the left PCOM, there could be a possibility of another one in the right one also. So before the bomb goes off, I would like to give structural support there in a sense that I'm diffusing that bomb. So we are going to go ahead with endovascular coiling. We'll be deploying two coils, both in the ruptured one as well as in the unruptured one, so that we can prevent the unruptured one from bursting, and we want to prevent the rebleed from the ruptured one. So I hope that makes sense now, that why are we going ahead with conventional angiography in these patients. And another investigation which they love to ask is lumbar puncture. It should always be guarded lumbar puncture in a setting of raised ICP. And well, what I'm going to do in this patient is obtain the CSF. Well, CSF will not give me any supreme advantage in the initial first few hours, because it will reveal bloody CSF. And all I can say at this moment is bloody CSF can be due to a traumatic lumbar puncture also. Though we can do a 3-tube test to differentiate between the two, because if you get a bloody CSF, you can differentiate between a traumatic lumbar puncture versus a subarachnoid hemorrhage, because in 3-tube test, if it is going to be a genuine traumatic lumbar puncture, then the amount of blood, because the moment there is a trauma, the clotting steps will get activated. So the redness of the sample will begin to progressively reduce. Why? Because there is a clot being formed. So traumatic lumbar puncture with respect to 3-tube test will show gradual clearing. But in subarachnoid hemorrhage, the bloodiness of the CSF will be universal. I mean, if even if you're taking it in 3 test tubes gradually, drop by drop, it's coming because you're doing a guarded lumbar puncture. In the 3 tubes, you will notice that there would be uniform bloodiness present, where if the bloodiness of the sample begins to reduce, it implies that it was a traumatic lumbar puncture. I'll just put that in brackets at the moment to say that traumatic lumbar puncture is one of the important causes for development of a bloody CSF. And he has asked in the exams in the previous year, that was I think combined medical services exam, he said that okay, in a bloody CSF due to a traumatic lumbar puncture, what is the source of bleeding? So the source of bleeding in that particular case would be answered as epidural venous plexus. This is in contrast to the one with respect to the Sylvian fissure, where I was talking about middle cerebral artery, or it could be like the anterior circulation, the ACOM, and the anterior cerebral with respect to the interhemispheric fissure. Now, if I'm going to repeat this lumbar puncture in this patient after 12 to 24 hours, then the RBCs will begin to break down. And the breakdown of RBCs will produce bilirubin, and bilirubin will be relatively yellowish in color. So that is why they love to ask about lumbar puncture finding in these patients for academic reasons, that they want to see that you are aware of this fact that there is a xanthochromic CSF in this patient. Xanthochromic CSF would mean that there is going to be bilirubin in the CSF. As far as xanthochromic CSF is concerned, it begins to appear around 12 to 24 hours. If in a MCQ 12 and 24 both are given, I would suggest you to answer as 24 hours. That's because it will take some time for the RBCs to break down to produce a substantial amount of bilirubin to cause that yellow tinge to be present with respect to the CSF. And then the peak of this xanthochromia can be obtained by approximately 48 hours. And then he can ask you that this xanthochromia will persist up to, then the xanthochromia can persist up to not days, but up to as many as 28 days, that is 4 weeks. I'll repeat the statements once again. It takes some time for the RBCs to break down. The range is 12 to 24 hours to give a substantial amount of bilirubin to be present, so that there's a yellow tinge in the CSF that is called as xanthochromic CSF. And the peakness of the xanthochromia is obtained by 2 days, and the xanthochromia will then persist for approximately 4 weeks or so. But point number 3 is more from academic reasons that I'm discussing, because most of the time, maybe in a peripheral center, we might be doing a lumbar puncture for diagnosis of subarachnoid hemorrhage, and that would be a risky maneuver to do. In contrast, most of the time, what we're gonna do is, if he just says what is the investigation of choice, imaging modality of choice, it's a CT head. And if he says what is the next best investigation, it's a conventional cerebral angiography. It's a combination of CT head followed by a cerebral angiography / a CT angio, whichever is feasible, so that I can now plan. Suppose even if I don't have angiography available, cerebral angiography in my center, if a CT angiography is telling me that there is a berry at a particular location, there's a cousin berry means umbilical berry aneurysm also present, then I can refer him to a particular center where proper treatment can be given. So our objective is a proper diagnosis of this patient. And now let us look at a couple of other investigations that can be done in these patients. And one of additional investigations that I would like to mention for this patient is ECG. Because this is an extremely painful condition. There can be so much of pain present that there would be an excess amount of catecholamines present in the circulation. That excess catecholamines can cause spasm of the coronary arteries as well and can cause myocardial ischemia. So do not be surprised if you notice in a MCQ subarachnoid hemorrhage ECG finding of T wave inversion given or ECG finding of ST depression given. The reason for this is myocardial ischemia. I'll explain that again. There's a massive surge of catecholamines, a spike surge of catecholamines due to this excruciatingly painful condition. Where I said the pain rating is going to be 10 on 10, patient will say, if you could allow me, I could have given a rating of 20 on 10. Right? So because of the excess catecholamines, there's going to be a coronary spasm, and that coronary spasm will cause myocardial ischemia. That will cause a T wave inversion. It will be written as TWI. Lots of time in our exams, no, they use short forms. Like especially if you're studying abroad, no, lots of time you may not be used to these short forms that we use back home here. So you need to get used to them. T wave inversion and then ST segment depression would be seen primarily because of myocardial ischemia. And another investigation that I would also like to do in these patients as a baseline is electrolytes. Especially I would be interested in serum sodium values of these patients. I have already explained that a large chunk of these patients might have already started developing hyponatremia. And in a setting of this hyponatremia, we'll be happy giving normal saline as a preferred fluid for these patients so that I can replete and bring the sodium back to normal. I don't want to end up in a situation where the sodium is less than 125 and then he starts having seizures. So as they say, prevention is better than cure. So if serum sodium begins to fall, what's the fluid to be given? That is normal saline. The advantage of fluid will be it will also help in maintaining the blood pressure. We would like to maintain the BP of the patients on a higher side. I'm not saying normal, I'm saying on a higher side because I want to maintain cerebral perfusion pressure. The biggest problem with patients with subarachnoid hemorrhage would be that the cerebral perfusion will begin to fall. One possibility is he can die on the same day. I mean, the sudden rise of ICP is going to cause death of the patient immediately. But once he goes into second day, third day, then a new problem will arise. And that new problem is that wherever that bleed has occurred, that's okay. But the surrounding blood vessels or wherever the bleed is present will now start exhibiting a substantial amount of protective spasm. And that protective spasm will then start resulting in development of delayed neurological deficits. One of the important reasons why these patients can die is development of DCI, that is delayed cerebral ischemia or vasospasm, which can result in delayed morbidity or death in these patients. You see, one reason why these patients can die is immediately because of combination of raised ICP and myocardial ischemia. I mean, the brain is also impacted, heart is also impacted, patient can die the same day. But then a large number of these patients may die maybe on the second day, third day, or even later, or even after a week. So delayed morbidity as well as the death component is a possibility in this condition. Like the same patient, though he has been admitted in a hospital, but he dies later. That's because of the protective vasospasm that occurs, because whenever there's going to be bleed, the area, the blood vessels which are surrounding wherever the bleed has occurred will now exhibit a protective spasm, and that's why cerebral infarction can be a reason for development of death in these patients as well. To prevent the development of this spasm, we'll be talking about nimodipine. I mean, the reason why we give nimodipine to these patients is to neutralize this delayed cerebral ischemia, which can contribute to development of delayed morbidity and death. And that's one of the important reasons why these patients can die. But this is not the only reason. I mean, this is just the tip of the iceberg. Another possibility can be development of re-rupture. The incidence of rupture in an untreated one can go up to a range of 20 to 30%. Huge value as I use. 35% was the mortality rate. So re-rupture can also be a reason for development of re-rupture, can also be a possibility, and a re-bleed. I mean, if it will re-rupture, there would be a re-bleeding that will be occurring, and this can be another reason why these patients can die. And this hydrocephalus can be caused by blood that can be occluding foramen Monro or aqueductus sylvius, and we can be mitigating or decreasing the severity of hydrocephalus in this particular case by going ahead with the external ventricular drainage. EVD here means external ventricular drainage, which means ventriculostomy, in which we'll put a catheter in the brain, and this catheter will have a one-way valve. The valve will open whenever the pressure in the brain will high, and it will drain the CSF out of the brain, and thereby I'm saying physics, if I reduce volume, the pressure will tend to come back to normal, and the one way valve will close, and therefore the pressure in the brain can be maintained. There are four reasons why there can be delayed neurological deficits or delayed deterioration in these patients. One is obviously they can die immediately. Second reasons can be that they can die subsequently. That can be ranging from re-rupture, hydrocephalus, vasospasm, and development of hyponatremia. If they ask you to select one out of these four and they say which of these is the predominant reason for a delayed morbidity and mortality, then the most common cause of delayed morbidity and mortality in these patients is vasospasm. The hyponatremia thing can be written in multiple choice questions in two ways. Either he's going to write the word hypovolemic hyponatremia, or another way to describe this can be the term cerebral salt wasting syndrome. Well, what was causing this cerebral salt wasting was release of BNP. Traditionally, we read about pro-BNP levels with respect to congestive heart failure, but then BNP is also released from the brain and thereby results in salt wasting. Then he can also ask you what test can be done by you to identify these vasospasms. So we can be using a invasive as well as couple of non-invasive tests. The best way is obviously conventional angiography, but then he can ask you about the non-invasive method for detecting the vasospasm also. So the test we can do as a non-invasive one is TCD, that is a transcranial Doppler. Apart from this, we can be doing a CT angiography or CT perfusion studies. And the best way is anyway the standard one, that is conventional angiography. And well, why conventional angiography again here will be preferred is because I can be giving intra-arterial. Like suppose on conventional angiography, if I'm able to demonstrate substantial amount of vasospasm of the entire anterior circulation or entire middle cerebral artery or entire posterior circulation, then I can be directly injecting vasodilators into the narrowed blood vessel. And suppose even if the vasodilators are not working, we can do a balloon dilatation of the narrowed artery also. I'll say that once again, why conventional angiography was being preferred after non-contrast CT said after a diagnosis of subarachnoid hemorrhage was one to facilitate deployment of endovascular coil, which will prevent the chances of rebleeding, rupture in these patients and can handle the mirror sites as well. Now we are doing a conventional angiography again on third day or maybe fourth day in these patients because they are not recovering and their GCS is still low, because we demonstrated that there was a spasm of the brain circulation because of which person is not regaining consciousness, and the neurological deficits have increased in this patient because spasm will anyway reduce and will worsen the cerebral ischemia component. So to neutralize the cerebral ischemia, either I can go ahead with intra-arterial vasodilators, or we can even do a balloon dilatation of these arteries so that, well, the cerebral ischemia component can be minimized. So it's a little difficult condition to manage in a sense that though the amount of bleed is very limited, you see meningeal space has very limited space, so the amount of blood is very limited, but the complications that are coming with it are so troublesome to manage that there is a high probability that we can lose our patients. And I would also like to mention a formula here which has been asked in the exam and you are aware from physiology, that is cerebral perfusion pressure. CPP is a difference of mean arterial pressure minus intracranial pressure. Mean arterial pressure in us is about 95 millimeter of mercury and intracranial pressure is about 20 millimeter of mercury upper limit. So CPP will be about 75. Normal cerebral perfusion pressure of you and me is between 60 to 80 millimeter of mercury. I mean, we survive in this narrow range. If CPP is more, there would be swelling in the brain. If CPP is less than 60, it will cause ischemia, it will cause brain infarction. Suppose due to subarachnoid hemorrhage, intracranial pressure will rise. Then you can see mathematically if ICP will become instead of 20 to 30, then cerebral perfusion pressure will begin to reduce. To prevent this decrease in the cerebral perfusion pressure, what the human body will do is it will exhibit a vasoconstriction, which will cause an increase in mean arterial pressure. And suppose if ICP will rise by 10 points, 10 millimeter, and mean arterial pressure will also rise by 10 millimeter, then the two will counterbalance each other, and once they will counterbalance each other, the CPP of the patient will remain normal. The main message is our objective for the management, because I'm going to talk about the management part now. The management of ours will revolve around that. Are we able to maintain the CPP of this patient in this normal range over the next couple of days? Because if we are able to do that, it's great. If we are not able to, if the spasm comes in, the CPP will be lesser. And if the CPP becomes higher, there can even be more problems with respect to either a re-rupture, re-bleeding, and even a development of cerebral edema as well. So our objective is to keep the balance of the blood pressure and the intracranial pressure so that the CPP remains in the normal range. I mean, that's the essence in entire neurology, that if we are able to maintain CPP for head injury patient, brain tumor patient, subarachnoid hemorrhage patient within a normal range, we'll be able to ensure survival. To assess the severity of subarachnoid hemorrhage, there are two scales that are available. You mainly need to remember the names of these scales. One of them is called as Hunt and Hess scale, and the second one is WFNS, that is World Federation of Neurosurgical Society scale. Both names are to be remembered for evaluating the severity of subarachnoid hemorrhage. And per se, I can say that if he will ask a question on this topic, most of the time it would be the name, but if he wants to get and make it a little more difficult for you, then I don't want you to remember the entire of the table, but I want you to specifically focus on WFNS scale, that would be grade 2 and 3. Because if you look at the data with respect to grade 2 and 3, you will notice that the GCS of this patient is 13 and 14 in both of them. But the difference between the two is that with respect to grade 2, there is no motor deficit present, whereas if there is presence of a motor deficit, we will say it grade 3. So remaining of them, the GCS values are anyway reducing. Like in grade 4, it's a GCS value 7 to 12. For grade 5, it's a GCS value 3 to 6. But the only difference or the point from the examiner's perspective is grade 2 and grade 3. The difference is that both would be having GCS values the same 13 to 14, but the difference is in grade 2 no motor deficit and presence of motor deficit with respect to grade 3. The names of the scales are Hunt and Hess and WFNS scale. And now we'll focus on the treatment part, where we'll go ahead with early aneurysmal repair to prevent development of rebleeding. There are two ways to prevent the development of rebleeding in the first 24 hours. One is the standard method of endovascular coiling, which will require a cath lab facility. But there is a second method as well, that would be in the form of aneurysmal clip. Now, the only issue is that if you want to deploy an aneurysmal clip, you will have to do a craniotomy in the patient. And the moment you do a craniotomy, then the hospital stay of our case will be dramatically increased. Nowadays is the era where patient's relatives and patient himself is interested, though this patient may not be in a position to quiz you, but relatives will always ask with respect to the duration of hospital stay, because longer is the hospital stay, the hospital costs will also go up. So on a comparison basis with respect to endovascular coiling and aneurysmal clip, both are very good ways to manage this patient. But on a comparison basis, because aneurysmal clip deployment means that you will have to do a craniotomy, and that means that the person's hospital stay in hospital will be substantially increased. So we prefer doing a endovascular coiling in our case. Along with this, securing airway is anyway important. Protecting airway in any raised ICP will anyway have to do blood pressure control. Our target cerebral perfusion pressure should be between 60 to 80 millimeter of mercury. You see, we keep on fretting and worrying about blood pressure. Obviously, our target blood pressure in this patient, or the systolic blood pressure of this chap, should be kept less than 160 millimeter of mercury, because in hypertension anyway, the chances of rebleeding will be dramatically increased. You see, I've already explained this formula to you, that from mean arterial pressure, if you subtract the intracranial pressure, that is how you are able to derive this cerebral perfusion pressure. So if ICP is increasing and MAP is also increasing, as long as the two are counterbalancing each other, the word is counterbalancing, as long as the increment of them is counterbalancing and the CPP is in a normal range, I'm not worried. Obviously, if I get a disproportionate increase in mean arterial blood pressure values of this patient, because he is a pre-existing known case of hypertension, then I need to intervene and lower the BP. Now, what are the drugs that I can be using for lowering the BP of this patient? I can be using beta blockers. I can be using nicardipine. So specifically, if he says for BP control, then don't answer nimodipine. Nimodipine will be used mainly to take care of the vasospasm. If he's gonna say what drugs can be used for blood pressure control in a case of subarachnoid hemorrhage, then the standard drugs that we use in neurology to control extremely high BP, like nicardipine, labetalol, esmolol, are the ones to be used. Even in the topic of hemorrhagic stroke, even in the topic of intracerebral hemorrhage, I've said the same thing with respect to high systolic blood pressure. We can lower it using nicardipine or labetalol or a short-acting beta blocker. And then the next step that I'll be using in this patient is a prophylactic anticonvulsant. That's because they can end up with development of seizures. If there's already an episode of seizure, I still have to be proactive. Even if there is none, I still need to be proactive and prevent a redevelopment. I repeat that again, if a seizure has not occurred, it can occur. And if it's already occurred, I anyway need to give a phenytoin drip for this patient. Now let's look at what can we do for vasospasm. We can be giving per orally nimodipine. So nimodipine is the drug of choice for management of this condition. But why are you giving nimodipine? That is to prevent the delayed cerebral ischemia that takes time to develop in these patients, is to prevent the cerebral infarction. It is to prevent the ischemic injury. So most of the time pathology people will use the word infarction, but we technically use the word ischemic injury because that's what's happening because of the vasospasm component. So to neutralize the DCI, the delayed cerebral ischemia, that can be detected by a transcranial Doppler or a conventional angiography, is the best way to anyway detect that vasospasm and can help in regaining consciousness in this person. So these are the drugs that we are using. If we are not getting an improvement, then we can even use intra-arterial vasodilators. Again, the vasodilators that can be used is calcium channel blockers only. And then if this vasodilator is not working, then we can also go in with the transluminal angioplasty. That transluminal angioplasty basically means a balloon angioplasty, dilate the blood vessel, reduce the cerebral ischemia, and help the patient regain consciousness. For the hyponatremia component, we'll be using normal saline as our initial weapon so that I can prevent the deterioration. Let me say sodium is 130, 128. I can use normal saline. But obviously, if this person can end up with development of seizures, then for acute onset hyponatremia, we have to give 3% saline bolus for this patient. That I'm not writing here because that is discussed in the kidney section, but still I've said it. Acute hyponatremia, suppose values 123, 120, it's causing seizures, I can be giving a bolus. For chronic hyponatremia, we always go in for a gradual correction. But if it comes to acute hyponatremia, that's within first 48 hours, then we can be going for a fast correction as well, because you just need an increment by a few points. Suppose 123, there is a seizure, increase it to 126, 127, seizure will stop. That's an increment of only 2 to 4 points only. That's not going to cause osmotic demyelination syndrome. Don't bother about osmotic demyelination and central pontine melanosis. If you have to upgrade from 123 to 128, that's a 4 to 5 point rise. That's pretty in the safe range, and you will be out of the woods in the sense that the seizure of the patient has been controlled. So if you want to get more into technicals of this, I would like you to listen to the electrolytes video that's in the kidney section. But still, I've given you a heads up. Even if you have not, I've tried to solve it before you. Acute onset hyponatremia, fast correction, good news. But when it comes to chronic onset hyponatremia, where patient has been sick for a week and even longer, then I'm going to give a slow correction. The max increment in gradual correction is going to be 8-point increment with chronic hyponatremia to minimize the chances of osmotic demyelination syndrome. We do not get ODS with acute onset hyponatremia. Point number 9 is a very neglected part of this entire discussion. So I want you to listen to this with a lot of care, because my patient is going to be lying in the bed. I would like to use pneumatic compression stockings, because in a scenario of immobilization, there can be deep vein thrombosis, and then the clots can go up into the lungs, and they can be a pulmonary embolism as well. And you might be saying, sir, what's the big deal? With pneumatic compression stockings, look at what I'm writing next. I'll also be using heparin. And the moment I say word heparin, the queries and the messages that start coming up to me, sir, in subarachnoid hemorrhage, there is a bleed. And in bleed, you are giving heparin to this patient. So now, I'm saying, Jara ruko and listen to the data. I'm giving heparin to this patient after 48 hours of having done a procedure, which was the process of deploying a platinum coil in the blood vessel. So after 48 hours of endovascular therapy, after 48 hours of endovascular coiling that I've done in this patient, that is when we'll be giving heparin. We are not gonna give heparin to a person who's had an immediate bleed. This is gonna be, heparin is contraindicated in untreated. Like suppose if I do not have a facility of a cath lab and I'm not able to repair it with the help of endovascular therapy, and neither do I have facility for an aneurysmal clip, and I'm trying to manage the patient conservatively, we are not gonna give heparin in the untreated berry aneurysm per se. If he has had a recent rupture, I'm not gonna use it. But if I have treated it, now there is an endovascular coil supporting that berry, so a berry which was damaged, so the chances of rebleeding have been substantially negated. Now I can be using heparin. So the message is use heparin after 48 hours of endovascular therapy. This would be in a similar sense, like even in patients who have had a brain hemorrhage, after 48 hours we can start aspirin. We do not give aspirin obviously initially, but later on we can give aspirin to prevent the redevelopment of stroke. Let me say 48 hours is far-fetched at the moment and the bleed was because of anti-clotting drugs. I'll start it maybe later. But the point is, because stroke can occur on a recurrent basis, in ischemic stroke anyway, we have to give aspirin, low dose aspirin to prevent redevelopment of stroke. What I'm trying to say is that heparin per se is not going to be given if there is an active bleeding going on at this moment. If it's an untreated berry aneurysm, I'll not give it. But once I fix the problem, no problem, because I have to prevent even the pulmonary embolism component that can be developing in this case. So the main crux from the previous two slides is the carry home message is, if he says what is the treatment of choice for a berry aneurysm, whether he says unruptured, whether he says ruptured, it's endovascular coiling. If he says what's the most common cranial nerve involved in unruptured and ruptured berry aneurysm, your answer is third cranial nerve. Yes, sixth nerve will be involved, but then that's a false localizing sign anyway because there is SAP, unless the berry is located in the cavernous sinus, in the internal carotid artery that is traversing the cavernous sinus. 2 points must know for this, where I see a lot of confusion happening, is what I've highlighted. That would be with respect to the commonest cranial nerve involved and what's the main treatment of choice for this condition. Agreed, the drug of choice is obviously nimodipine. I mean, no dispute about that, but this is going to prevent the DCI component. But the acute management is the one that has to be taken care of. So these are the details that I would like you to remember. And well, the message at the end is that life does not become easier as with time. It's not that as we grow older and if you make more money, life is going to be easier. It's still going to have its own set of challenges. So it's over time, it's we who have to become stronger. And well, how will you become stronger? By learning all the technical facts that I've told you. So keep the pressure on, keep on learning everything, keep hammering, and see you again in another video.